So the first presenter is Dr. Carolyn Eberdt. Dr. Eberdt has worked as an emergency physician at St. Paul's in Vancouver since 2010. She graduated from medical school at McMaster and completed her residency at the University of British Columbia. She has special interests in population health, trauma medicine, and medical education. Since 2014, she's been part of the Lionsgate Hospital trauma team, and since 2016, she's been the education coordinator in the St. Paul's Emergency Department. Now Carolyn is probably one of the most cheerful, positive emerge docs you guys will ever meet in your life there, so she always brightens up the department, and it's a real pleasure to have her. So please welcome Dr. Carolyn Eberdt, and she's going to be talking about rib fractures.
Well, hello everyone and welcome. For the next 15 minutes, we're going to talk about rib fractures. I have nothing to disclose. So we're looking for some answers. We're going to look at how to optimally diagnose rib fractures using chest X-ray, ultrasound, CT, when we want to think about each of those, re-examining the evidence for treatment, determining which patients we can safely discharge, and looking at the rates of delayed complications. In answering these questions, we're going to focus on minor thoracic trauma. The literature defines this as a superficial scuff or abrasion on the chest wall. A patient you anticipate is going to have 1 or 2 rib fractures. They're usually ambulatory. Patients that are not automatically destined for the scanner. You probably have them every shift, maybe every second shift. Why do we care about this? Well, there's huge discrepancies in our care of these patients across Canada. Shields et al. Did a study over 600 charts reviews, 4 hospitals. The admission rates varied between 1.5% to 23%. The bounce back rates were 20% of these patients. And on 50% of charts, there was no discharge advice documented and no discharge prescription provided. In fact, if you were over 65, you were less likely to have any discharge advice. So we have an opportunity here for perhaps improving our care. We have a misguided appreciation, I feel, after doing this literature review, of the rates of delayed complications. I think most of us have counseled around the risk of pneumonia, which is in fact almost minuscule. There are a few other complications that I want you to remember at the end of this, delayed hemothorax being one of the more frightening ones for me. Finally, in older patients, rib fractures are a huge marker of morbidity and mortality. In fact, an older patient with 5 rib fractures has a mortality rate of 25%. So that's huge. So starting off, does my minor thoracic trauma patient need a chest X-ray? You have a 48-year-old guy who's previously healthy, standing on the bus, it stops suddenly, and he falls onto the edge of the ticket dispenser. He walks into your department, and he has anterior chest wall pain, normal vital signs. Do you do an X-ray? Do you do it to look for a rib fracture? Are you looking for a pneumothorax? Do you do it because you always do it? Or do you do it as a therapeutic X-ray because the patient anticipates it? Well, if you're doing it looking for a rib fracture, we all know we don't see most rib fractures on chest X-ray, but they miss a whopping 50 to 75% of rib fractures on X-ray. So that's dramatic. So maybe not doing it for that reason. Ultrasound may offer the information that you want. It has a higher sensitivity for both rib fractures and pneumothorax than chest X-ray. For rib fractures specifically, the sensitivity was 80% versus chest X-ray 24%. Fairly easy, there was a feasibility study performed in a CGEM article. Quite easy for emerge docs to learn. You take the linear array probe and then you glide it along the rib, which is probably one of the more difficult parts because the ribs are curved, and find the area of maximal tenderness. If you don't see a break in the cortex there, give a gentle compression to perhaps reveal a buccal fracture, and then doing the same for above and below. Fairly easy to do. Drawbacks to perform properly, it takes a fair amount of time, and you can't get those subscapular ribs or the infraclavicular rib. So you've got the X-ray. What about a rib series? A rib series, in fact, does pick up a fair amount more rib fractures. However, numerous studies have shown it rarely changes the patient's disposition. In fact, the only thing it will do is if you see a fracture, you're much more likely to prescribe pain medications. So if you can be aware of your own biases, and if you don't see the fracture, still create a pain control strategy, perhaps you can reduce your length of stay by not doing the rib series. An inverted series, this is a trick that I was taught at least. Another study showed that it will improve the pickup for junior learners, but if you're a seasoned emerge doc, you're probably not going to pick up too many more by doing an inverted series. But if you're not used to looking at me, want more comfort, why not? And finally, one more tip is tipping the X-ray on its side. There's a number of radiology blogs that say this improves your pickup of rib fractures. So which of our patients want or warrant a CT chest? Because we don't see like necessarily it's always the minor. We don't know. It's a nice spectrum between the minor going into the major. I want you to imagine two patients here. The 79-year-old trip and fall, osteoporosis, tons of chest wall pain. And then we have our 28-year-old ped struck. Reports say that they've been thrown 8 feet. They're in a C-spine collar, no chest pain. Both have normal vitals, normal chest X-ray, normal bedside ultrasound. If you go look across the country, you're going to see huge discrepancies in what one center does given another center. There's been a dramatic increase in just pan scanning a lot of patients based on mechanism. So you hear a report thrown 8 feet, that's a big mechanism. Let's just throw them through the scanner. Whereas, in fact, the patient on the left is probably going to have a lot more, it's going to affect their management potentially a lot more. CT is going to pick up 75% more rib fractures, so that's good. However, if you have a normal chest X-ray, CT was reported to change your management in 1 in 67 patients. So that normal chest X-ray is a reassuring finding. Now, interestingly, there's been a clinical decision rule to help us tease out some of the intricacies in this. Everyone's heard of the Nexus rules for C-spine. Here we have Nexus Chest, derived and validated using 11,000 patients, so a pretty big number. And these are the criteria they came up with. Abnormal chest X-ray, distracting injury, something that you deem distracting the patient from any chest wall pain, and then pain in the chest wall, sternum, thoracic spine, or in the scapula. If all are absent, you can safely forgo the CT chest. If you have any one, consider doing the CT chest. This by no means you have to do a CT chest. When they derived this rule, the aim was really to reduce the number of CT scans that we do in this pan scan era, where a lot of patients are just being thrown through the scanner. However, it's an interesting extra tool that you can use. Put into MD Calc and see where your patient rates. Immediate complications I want you to consider. So depending on where the fracture is, there are certain injury patterns you may see. Ribs 1 to 4, really pay attention. Especially if you have a cyclist comes in, maybe they were ambulatory, they were just thrown off their bike. If you see a rib 1 to 4 injury, this possibly suggests that the force was a lot bigger than you had appreciated. Maybe vascular nerve injury. Ribs 5 to 9, pulmonary complications, your hemothorax, pneumothorax. Ribs 10, 11, 12, really thinking about the underlying liver and splenic injuries, especially if they're under 55, because the idea is that if the force was big enough to produce, cause a fracture in the under 55 rib, it was a stronger force that may have been transmitted to the organs underneath. And thinking, does my patient have a pulmonary contusion? A bruised lung underneath that could decompensate over the next 48 hours. Counting the respiratory rate, looking at the oxygen saturation. Fortunately, 6 hours after the injury, you often see some signs of pulmonary contusion there. Treatment and pain control. Chronic pain is an issue for some of these patients. There's been numerous studies looking at 3 and 6 months out that patients do have a fair amount of pain. 20 to 30% of patients, so a fair amount. More displacement and more fractures correlates with more pain. Bugev et al. Did a nice study showing the quantity of opioid increased consumption based on the millimeters of displacement done. Unfortunately, there's no consensus as far as the best treatment. The 2006 East guidelines really had proposed epidurals. Epidurals probably are not the be-all and end-all now, what they found in their 2016 guidelines, associated with more complications than we had previously appreciated. They're still recommending a multimodal approach, using your Tylenol, your NSAIDs, your opioids, and considering blocks as well. There's a number of different blocks you could consider, either doing yourself or involving your anesthesia colleagues, paravertebral, interpleural, intercostal, but the one I want you to remember is called the Serratus anterior block. And this is one that you could consider doing safely in your emergency patients. You can do it with ultrasound, or the American Journal of Emergency Medicine proposes even without ultrasound. The serratus anterior is a muscle layer that goes on top of the external intercostals, and the idea is you put the anesthetic there, it diffuses from the lateral cutaneous nerves into the intercostal nerves. And if you are lucky enough to be doing the regional anesthesia workshop at this conference, it's going to be taught there. So better try to get in on that. A few more notes on treatment and pain control. There's an interesting study looking at over 770 patients that Toradol was associated with lower rates of pneumonia. This was even though there were higher injury severity scores in the Toradol group. I think this is probably more reflective of the multimodal approach that may have been used in these patients where they got NSAIDs, but an interesting study nonetheless. I found this interesting that a few studies have looked at this idea of topical lidocaine 5%. So in the United States, they have 5% lidocaine patches. Unfortunately, we don't have those in Canada, but we do have the ointment. And the idea is you put it on the area of discomfort. You don't have to worry about local systemic toxicity because unlike a fentanyl transdermal patch, there's no transdermal delivery system in just applying the topical ointment. So it is something that's worth a try. The studies showed patients didn't take less opioids, but they did have improved pain scores. So an interesting thing to think about. TENS, there was a recent Cochrane review that showed promising evidence that possibly TENS can help for acute pain from rib fractures. No matter what you do, create a pain control strategy with your patient, even if you don't see that X-ray fracture and you believe they have a rib injury. Two final notes on treatment and pain control here. Incentivespirometry is still part of most guidelines. In the United States, they give this out routinely when patients have rib fractures. There's no real evidence that it prevents adverse outcomes. Taping and rib belts, I found shocking. I don't know, can I get a poll of people in the audience recommending this to patients? Put your hand up. Like nobody, because that's how I was taught, that they were awful. There's an entertaining EMRAP blog that this recommendation not to use them was based on two minuscule studies, 20 and 24 patients. So we don't really have good evidence either way for rib belts. I just found that an interesting thing. So is it safe to discharge the patient? We don't have clear guidelines for the patient with minor thoracic trauma, but through the literature I read, you really want to think about, does the patient have pulmonary contusion, especially when they're minor? If you're unsure, having the X-ray done at 6 hours is going to give you more information because you're probably going to see signs of it on the X-ray at that time. If you're really unsure, even getting an ABG that shows the AA gradient will increase as an early marker. Give some thought to admitting your patients over 65, especially if they have multiple rib fractures, because they are very high risk for decompensating over the next while. More than 3 ribs in anybody, displaced ribs, and pre-existing lung disease. So how do we prevent and anticipate complications? Delayed pneumonia. I think most of us at some point have counseled our patients around the importance of deep breathing exercise and preventing pneumonia. This is true for only a very small subset of patients. Canadian prospective multi-center study looking at over 3,000 patients, they found their incidence, this is outpatients, patients seen in the emergency department sent home, 0.6%, very small. Very similar study done with also several thousand patients. This was in Taiwan. When they just isolated out rib fractures sent home, 1.6%. It's low. Focus your counseling on those over 65, those with pre-existing lung disease and multiple rib fractures. In both of the studies, those are the patients that went on to develop pneumonia. But we don't have to counsel everyone. It is a very rare complication. It doesn't hurt if you want to add some extra counseling, but really regular pain control is probably an area we should be focusing more on. Delayed pneumothorax in discharge patients. So the patient has a normal chest X-ray in the emergency department. They go home, they come back with a pneumothorax. This was actually more frequent than pneumonia. So 5.4% in one study, 1.9 in the other. And when I mentioned that Canadian multi-center retrospective review, chart review of minor thoracic trauma, it was 3.5% in that study. All of these patients came back on their own. They didn't have scheduled follow-up within 48 hours. In half of those cases in both studies, they required a tube as a means of intervention. So these weren't tiny pneumothoraxes. These were actually ones that sometimes did require treatment. Delayed hemothorax in discharge patients. So for me, this was a terrifying new area to read about. Mitos et al., this was a fairly large European study, well, fairly large being 3,000 patients. Minor thoracic trauma rib fracture patients discharged home on the day, so not inpatients. Their rate of delayed hemothorax when they followed patients up at 7 and 14 days was 7%. Most of the patients in this study did require some intervention, and they quantified the amount of fluid on those patients' imaging. I found this humbling. A recent Canadian clinical decision rule was performed, and this looked at several thousand, I'm trying to remember how many thousands. It was several thousand patients, prospective study. their rate of delayed hemothorax was a whopping 11%. However, in this study, they did not quantify the fluid. It was merely presence or absence of the fluid, though they did take all of this data they collected and created a clinical decision rule for us to help predict who is going to come back or may need follow-up. So there's a 5-point scale. I wish this had a catchy name for us all to remember, but they didn't think of any catchy name. If you have one, we should write the authors. If you had points of 4 or 5 points, you had a 30% risk of having a delayed hemothorax, so fairly high. Some we would expect, age over 70, ribs 3 to 9, age 40, 5 to 70, and 3 or more ribs. So we can't ask all of our patients to come back for follow-up chest x-rays, but we could have some of them come back. I should mention, in that study where there was 11% of patients, not very many did require drainage in the end. So how we interpret these findings, does have a caveat. But I think 5 points, I probably will recommend the patient have a follow-up chest x-ray. Finally, in reviewing the literature, there's an interesting subset of literature. It's like the world's Guinness Book of longest delayed hemothorax. The longest I found was at 44 days. This guy had a trip and fall at home, went in, had a chest x-ray, 2 rib fractures, no fluid. 44 days later, has acute dyspnea, goes into the emergency, and has 1.8 liters drained off his chest. So I think we should all take this as a challenge and look for a more delayed one. Take home pearls. The pain is real and lasts a while. Even if you don't see a rib fracture and you choose only to do a chest x-ray, consider that they may have a rib fracture and create a pain control strategy with your patient. Ultrasound may help you avoid x-ray and may help you pick up a few more rib fractures than you had before. Consider using the Nexus Chest CT in some of your patients. Give blocks or topical lidocaine a try. Respect your elders. These are the ones that do worse, that do develop pneumonia and do develop delayed hemothorax. And perhaps our risk of pneumonia is overblown. Thank you all very much. At the end of the day, perhaps laughter is the best medicine.